Yeah, a very good morning to everyone. Uh, the topic that we are going to discuss is pterygium. There has been an evolution, a revolution in evolution over the decades, and we are just trying to highlight how it has happened over the years. So we begin our session with talk from Dr. Praful. He'll be telling about an overview how historical background and the conceptual evolution for both.
Thank you, sir. Thank you for letting me be a part of this IC. And thank you to the delegates. At least we have 10 delegates at 10 show. So, good morning, everyone. So, I'll be discussing an overview about how the pterygium concepts evolved over a period of time. Pterygium, you all know, it's the vascular fibrovascular growth of conjunctiva that encroaches your cornea. So, coming to pathogenesis, now the thing that sunlight exposure may be the cause of pterygium, it's known since years. Over a period of time, our understanding has become little bit better. For example, how does a UV ray exactly causes pterygium or a fibrovascular growth? So there are several mechanisms. First, it may activate the growth factors directly. There are fibrocytes in the tenons and the adjacent limbal area. Your UV ray may stimulate those fibrocytes to release some growth factor, and that will lead to fibrovascular growth and encroachment onto cornea. But why would a fibrovascular growth encroach onto cornea? Because there is a barrier that is normally not letting the conjunctival cells to grow over cornea. If you breach that barrier, then that is going to allow the fibrovascular growth to grow on your cornea. So UV rays simultaneously, it may be damaging the stem cells, which are the natural barrier to conjunctiva growing over cornea. So that may be the reason for this fibrovascular growth to go and move on to the cornea. And why it is uncontrolled? Simple. P53 is an anti-tumor gene. Whenever an anti-tumor gene is damaged, then the growth becomes unregulated. So P53 mutation again, maybe because of the UV ray, maybe the third factor that is allowing the conjunctiva to grow abnormally as well as encroach onto the cornea. So this is the evolution of thoughts. I think largely this is settled now. It's because of this only pterygium occurs. So we often refer to Western literature, forgetting that we had a great history, Indian medical history. And I was amazed when I was preparing this PPT that this is a line from one of the book by Susruta. And if you read it carefully, he has discussed all the aspects of pterygium in the single paragraph. So what he has described here is how to approach a case of pterygium. The pterygium is sprinkled with salt, that means anesthesia. Okay, nowadays we are putting anesthesia, that salt may be synonyms to anesthesia. The patient looks laterally, and most superficial part of pterygium is cleft with a hook. So we also do that, right? In pterygium topical surgery, we ask the patient to look that way laterally, then we hold the pterygium with a forceps. That may be this hook. Okay, then the pterygium is detached from the ocular surface with a knife, with a rounded end but sharp cutting edge. So imagine the concept of crescent knife was there with Sushruta that time. He has perfectly depicted in this quote. The remnants added to the eye must be eliminated. So look at the clarity of thought we had. We understood that okay, the mass need to be removed. Again, we understood that if you leave any remnant, that is going to recur. So the remnant has to be taken care of. An unguent applied. Unguent means some chemical maybe that time, and it took almost as 2000 years to find out that okay, we can apply MMC. But he had that concept. You have to apply something to the residual bed that will prevent recurrency. So that was the greatness of our science, our literature. Unfortunately, we ignore that quite often. So this is the first surgeon Baptiste who performed this pterygium surgery. That time there was no concept of anesthesia in Western literature, but if you look through that Susruta's quote, he used some salt, maybe some form of anesthesia. So you have to tie the patient and pull it off by passing a suture beneath the pterygium. That was the initial procedure was done by Baptiste. Then subsequently people realized that okay, the anesthesia was developed. Then people started doing surgeries, And this technique, which quite I think this technique was popular for almost 50 years, half of the century, Bessler technique. So what people used to do is that just hold it and pull it off, but the recurrence was too high. So the patient, a very common thing that usually we do, if a tiger is coming, do some shouting so that he will go to some other house but not come to us. So what the cornea surgeon thought, ki if this growth is coming onto cornea, let's divert its course. So let's cut it and put it inside the subconjunctival tissue superiorly and inferiorly, so it will not recur onto the cornea. But again, the recurrence was too high with this procedure. Then few people believed, okay, let's do a pediculated conjunctival flap. Pediculated means don't take a graft. Even few people do this nowadays also. So have a blood vessel connected to that, and then cover the bare area with that pediculated conjunctival flap. Finally, the gold standard nowadays, the most popular technique, conjunctival autograft, that came into foray by Kenyon et al. In 1985, and the technique is so good that it's still there. And any technique that is persisting over 40 years, that means it is probably the best technique that we have. However, the only controversy after that was how to attach the graft, whether to apply suture, whether to apply glue, and then recent addition to that is autologous serum. So so this is a video, I'll just run through it because I think Dr. Ikeda is going to show you a collection of videos. So this is the basic technique, how it is done. So this is what I normally do: mark the limbus. Few surgeons believe you have to take out the entire mass, but what I believe, you just need to remove the pterygium from the limbus. So mark it, don't over enthusiastically cut the pterygium. So this mark will guide you, there is where you have to cut. If it is a fibrotic mass, you can use crescent. More quite often it is possible to just hold it with a knife and pull it off. Whatever raw surface is there, you have to smoothen it out. And this Stein's tissue, which is there adjacent to conjunctiva, and there are controversy, few people do an extensive resection with excellent results. Okay, that Dr. Alok Sethi is going to cover in his talk. Smoothen the surface, as Sushruta highlighted, you have to take care of the bed, so smoothen it and then apply some adjuvant. Graft, conjunctival limbal autograft, conjunctival autograft. Few people believe that you have to take a piece of limbus. Why? Because the hypothesis suggests there is a localized limbal stem cell deficiency. So if you take a piece of limbus along with you, that will recreate the natural limbal barrier. However, in primary pterygium, often it is not required. You can simply put a conjunctival graft. That is also good enough. Why? Because limbal stem cell, if you damage the just 1 clock hour, 2 clock hour, the rest of the limbal stem cell can supplement that area. So that is the concept behind not taking a limbal graft. So I usually avoid a limbal graft, sorry, yes, conjunctival limbal graft in primary pterygium. But in recurrent pterygium, you have to take a limbus piece with that. Application of glue, that is best if your patient can afford. If patient cannot afford, don't hesitate to do a suture procedure. Autologous blood for small pterygium, not for more than 2. So these are the studies to highlight how to apply, whether glue is better or suture is better or an autologous serum is better. In summary, if you go through all these RCTs, I have included RCTs only. The third RCT by Sari et al., it probably summarizes the overall approach, how we should proceed. If you put a suture, the duration of surgery will go up 5 seconds by, so not much more, maybe 5 or 10 seconds or maybe 1 minute. But the problem may be post op course. Sutures induces inflammation, and remember, recurrence of pterygium is primarily because inflammation persists. So that is a factor that you should always consider while putting suture. The chance of recurrence may go high with sutures, although most of the studies, they don't say that, suggest that, but that is definitely a theoretical risk. Autologous serum, you are in private practice, you don't want to take a patient again to OR simply for a pterygium surgery. So it's ideally, for me, it's better to apply glue if the patient can afford. If cannot afford, go for a suture. But if pterygium is less than 2 mm, you can still consider for autologous serum. So consider these 3 factors while deciding how to attach your graft. Recurrent pterygium, as I've said, there are 2 primary causes. One, post-op inflammation, which you are not able to control. Second, there may be some smoldering inflammation that was there before surgery, and After surgery, that still continued, which we haven't taken care of. Third, there are fibrocytes which have been damaged by UVA rays and you haven't removed them adequately. These fibrocytes again they stimulate growth of the pterygium. So these are the three possible mechanisms for pterygium. So to take care of that, what people do, either as I said earlier, put a limbal transplant so that that will take care of the barrier part, or buccal mucosa. I won't suggest this. Even nobody does this nowadays. Amniotic membrane, yes, it provides you growth factor, it has anti-inflammatory action, it has anti-fibrotic action, so that will help you in preventing the recurrence. And another important role is when the pterygium is too much extensive, or you have a double-headed pterygium. There is a the raw area that you get after pterygium extension is too high, too large, you know. So it's unfair to take out normal conjunctiva for 6 to 8 clock hour and put it there. So in those cases you can go for AMG adjuncts. As Susan has highlighted, you have to apply some unguent, or I don't know how to pronounce that word. So these are the basically those things that we have developed nowadays. Corticosteroid is a mandatory. If you expect it's a young pterygium, fleshy pterygium, recurrence is high, please continue steroid for a prolonged period of time, because persistent low grade inflammation, which may not be apparent clinically, that could lead to a recurrence of pterygium. Thiotipa, earlier people used to do that. It's not required. It's too toxic for a disease like pterygium. Cyclosporin A, people have seen again the mechanism is same, immunomodulation and decreasing inflammation. Sorry. MMC, I think this is the most commonly used drug. Again, it approaches the same way. As I said, some fibroblasts may be there which are still active, and that may lead to recurrency. So MMC take care of those fibroblasts. But while using MMC, be careful. Use a low strength and as less time as possible. Don't over enthusiastically keep it for more than 30 seconds. It's going to damage your normal cells also. Lastly, VEGF inhibitor. It's not if your patient can afford. What I feel, there is no harm in using this. But the problem is it has a transient action. The effect will be for 4 weeks. So most likely, what it does is it will reduce the vascularization, so intra bleeding will be less. And the second point that often we miss, the inflammation in the immediate period is high. So your VEGF inhibitor will cover that immediate post-op period where the inflammation is high. So after 4 weeks, even if your VEGF is not acting, you have crossed over that immediate post-op period where the inflammation tend to be high. So VEGF inhibitor should work theoretically. However, studies have not shown any significant advantage. Adjuvants, other adjuvants like people do cautery, laser, 5FU, radiotherapy, interferon, but people have tried this in history, but none of them has been reached that popularity as MMC. Tenon's-Layer excision, Dr. Alok will cover this. These are the two technique, perfect and perfect. Perfect means remove the pterygium and then you ligate or you bridle all the muscle and take out as much tenons as you can. The hypothesis is that because tenons tissue harbors the fibroblast, which can lead to your recurrence. So that part Dr. Alok Sathi is going to cover. With this, I'll conclude here. Thank you for your kind attention. Any questions? I would love to take that.
Very lucid presentation, Dr. Praful. Any point from anybody? Any clearance from anybody? Otherwise, we go to the next speaker.
Yes, that's what I of the graft. See, whenever you use MMC, the rule of thumb is you have to wash it thoroughly with normal saline. You have to ensure no trace of MMC is there on your ocular surface before putting the graft. And your graft should be placed, because we have a tendency to excise the pterygium and then prepare the conjunctival graft and then apply MMC. So if you are using MMC, what I do, first excise the graft, then I apply MMC, then I wash the surface thoroughly, then I prepare my graft. So that is one way you can use, you can practice to avoid damage to your normal conjunctival or limbal stem cells. Thank you, sir.
Thank you, Dr. Praful. Now, I request Dr. Vijay, because he has to leave before, to discuss on the perfect technique. Basically, we have framed this IC in the sense that we have gone into the historical part first, followed by what is the gold standard, and then perfect and
Very warm greetings to all of you. I'll be covering the perfect technique. Let's see how perfect is this. So, for last 3,000 years, we have seen that pterygium has troubled the doctors, the ophthalmologists. There are more than 50 surgical techniques which are described, and there are more than 1,500 peer-reviewed articles about the pterygium. But still, there is no consensus that which technique is best for which type of pterygium. S- in 2008, Dr. Lawrence Hurst he came with a technique which he termed as perfect technique. Now, what is perfect? Perfect is pterygium extended removal followed by extended conjunctival transplant. Now, what this technique is? Now, let's see. This is a small animated video for this. Incision is given at the limbus, and the corneal part of the pterygium is removed. Then an extensive dissection is done of the conjunctiva and tenons, and the muscle on the side of the pterygium is hooked, and that is pulled. And then there is extensive removal of conjunctiva and tenon tissue is done till the medial canthus. Now, the proposed this technique basically the why this technique is theoretically successful is because the pathology of the recurrence of the pterygium lies in the tenon's tissue. If any amount of tenon tissue is left closer to the limbus and even till the muscle, then that will cause a recurrence. So, in this technique, after this is done, a conjunctival graft is taken, a large one, and that is transplanted over that area, and you can suture it or you can glue it. This is now in a patient. Now, same thing, you demarcate the pterygium at the limbus, and also you mark your areas till where you want to excise the pterygium. Now, at the limbus, you just cut the part, you split the pterygium into two parts, and then you can either avulse off the part which is overlying the cornea, and you remove that part, or you can do a fine dissection in one plane so that there is not much of irregularities over the cornea left. So this the after the corneal part of pterygium is excised. Uh, it should be nicely excised. No part of the pterygium should be left. Then you do a blunt dissection and you open up the tenon's capsule, and you do a blunt dissection posteriorly over the muscle. Once you have done this, you can see now tenons and conjunctiva are separated. Then you hook the muscle. You have to pull it nicely anteriorly. So you can see the muscle is now hooked, and then you do a further dissection beyond that. Normally, in conjunctival autograft, we do say 5 to 6 millimeter of conjunctival transplant. Here we go around 12 to 14 millimeters. So there the entire tissue, the subtenon tissue, the conjunctiva, all that part is thoroughly removed so that no fibrotic tissue is left behind. So once you have done it, then you prepare your conjunctival transplant accordingly, and after cutting your transplant, so that is transferred. You can use glue. Here we have put the glue at the base. But for the posterior part, what I do is, at least in the posterior part, I put three sutures, because if it gets dislocated from the posterior part, you may have to hook the muscle again to reach the other part of the conjunctiva. So posteriorly, I put three sutures. Rest of the part you don't require to put anything. You can use the glue. Otherwise, if you want to put another two sutures at the limbus to fix the graft, you can do that. So this is after the completion of the surgery. It was a recurrent pterygium with a huge fleshy mass. So this is after the surgery on the table. So why this technique? Now, as I told, it was in 2008. 250 patients were described with primary pterygia. They were followed up for 1 year. There was zero recurrence and excellent cosmosis. Then in 2009, 111 patients with the recurrent pterygia, they were followed up for 1 year. zero recurrence, excellent cosmesis. Then in 2012, there were 1,000 patients with primary and recurrent pterygia who were followed up for more than 1 year. There was one case which had recurrence. Rest of the cases were absolutely normal and excellent cosmesis. And in 2020, now there are 10 years, the patients have undergone 10 years follow-up. And 1,000 patients with primary and recurrent pterygia, zero recurrence and no cosmesis. So, has it addressed the problem of recurrence of pterygia? Yes, as per the studies published in the literature, more than 1,000 patients followed up for 10 years with zero recurrence in so many patients, and cosmetically, the results are excellent. If you compare to other techniques, as Dr. Praful had pointed out, the recurrence rate with other techniques, here in one subset of patients, there was only one patient who had a recurrence. Rest around 2,500 to 3,000 patients, there was no recurrence overall. So, is this perfect? No. What are the disadvantages of perfect surgery? Now, this is a lengthy procedure compared to a normal conjunctival autograft. You need a meticulous tissue handling. You may have patient may have transient diplopia because you're doing the muscle handling, and also there may be some post-operative pain. But the other part is it a step closer to perfect pterygium surgery as there is no recurrence and better cosmesis? Yes. With this I finish. I have around now 35 to 40 cases which I've done with this technique, but I normally select the cases which have got extensive fibrosis, which have multiple recurrences. In those cases it's working well and I had no recurrence till now. Thank you. Sutures you can remove after about say 2 or 3 weeks. Once you see that the graft is well taken, then you can remove. No, you can do that. Only thing is here, yes, yes, absolutely. You can remove the sutures as early as possible. There are no recommendation for that. There are no recommendations for removal of sutures. It's up to you. If the Yes, you can remove that. Even if you don't put a suture, that is also okay. His patient is ready for undergoing a second surgery in case required. That suture we have kept only because we are going quite posterior. Maybe now that part where you are putting the sutures and the posterior part of the pterygium where you are applying the sutures, that may not be visible. So if you have to redo the surgery, you may require to hook the muscle again. That is the only reason. Otherwise, you can just go get away with the glue. Glue normally holds.
So,
Glue normally holds.
actually, in the traditional perfect technique that has been described, glue has not been used, only sutures are used. The reason being it's such a large graft that you're going literally up to the medial canthus and up to the superior rectus, superiorly and inferior rectus. So, it's a very large graft. There are more chances of it getting dislodged, especially posteriorly, as he rightly said. So, in the traditional technique, no glue has been used, sutures have been used. But yes, of course, we can modify the technique depending on our comfort level and our experience. We can put a few sutures, maybe remove them early, put a large bandage contact lens.
Yes. No problems. It's up to your choice. You have to select out the individual's choice whether the patient can pay for the glue or you feel more comfortable with the sutures. So entirely your perspective depending upon the patient. Yes. See, some amount of inflammation because that part is conjunctiva and subconjunctiva is already inflamed, and there may be thick scarring which is holding the two things. So, uh, I think should be avoided because here you are taking up a case which is undergoing a recurrent pterygia and already there must be a lot of fibrosis. So, better to avoid that.
Sir, I'll answer that question while I'm giving my talk why we can't use the same conjunctiva.
Thank
Thank
you, Dr. Vijay. Now I request Dr. Ikeda to speak on the gold standard of pterygium surgery. So, see how we have conceptualized this whole talk is firstly we have to give the historical aspect and then the gold standard technique, which she will be rattling out right now, followed by the advances in the management of the pterygium surgery, which has started from the perfect technique, then mini slet and the permi slet. So there is a little deviation from the protocol, but yes, it's fine. So over to Dr. Keda.
Hello, very good afternoon, and I'm very thankful to all of you for being here, even though it's the last day. I'll be talking about the gold standard, which is pterygium excision with conjunctival autograft, and emphasizing more on the different securing techniques and how we have evolved. So now when we look at pterygium, we are basically have two goals of treatment. When we are operating a pterygium, we have to keep two things in mind. One, this patient wants excellent cosmesis. Second, we have to minimize the chances of recurrence. And if you look at the studies and you look at the literature, conjunctival autograft actually suffices and fulfills both of these goals. It was described way back by Kenyon et al. In 1985 and still holds as the gold standard. Now, preoperatively, the anesthesia could either be peribulbar or subtenons. I would, avoid doing these cases under complete topical anesthesia. It would be quite painful for the patient. The position of the surgeon could also be either superior or temporal, depends on your comfort. So I typically like to operate these patients in a superior position. And instilling topical brimonidine a couple of minutes before the surgery actually causes vasoconstriction and decreases the bleeding intraop. So this is something we can use. Now, before we talk about the surgery, let's really look at a pterygium and understand the pathophysiology and the parts of a pterygium. We have the head of the pterygium. This is the part which ovalize the cornea. Then we have the body of the pterygium, which is the part which arises from the conjunctiva. The junction between these two is the neck of the pterygium. And this whitish tissue that we see here is actually the elastotic degeneration, and this degenerated tissue we need to excise. So coming to Sir's point, this is not a normal conjunctiva. That's the reason why this patient has pterygium in the first place. The normal conjunctiva is not going to cross the limbal barrier and overgrow. There is some amount of conjunctival and subconjunctival degeneration, and that's why ideally I don't think it is a great idea to use this degenerated tissue. Now we talk about whenever we want to perfect a surgery, it is always helpful to break it down into different steps and understand the nuances of each step, and then understand the whole surgery per se. So I'm breaking it down to different steps. First step is excision of the head of the pterygium, then followed by dissection of the subconjunctival tissue, then harvesting the conjunctival autograft and securing in the graft in place. So I'll be concentrating more on securing the graft in place in the later time of my talk, because that's the evolution that we are going to discuss. So first, let's start with the basics of the surgery. That is, how do we get rid of the head of the pterygium, that is the part on the corneal surface. So here two videos here. In the first video, we have stripped off the head of the pterygium using a sharp forceps, and then we are excising the neck of the pterygium and subsequently using a number 15 blade to clear off the remnant tissue. In the second video here, we have first freed up the head by excising the neck of the pterygium, and now we can use two sharp forceps, one to provide counter traction, and then just strip it off from the corneal surface. Whatever works well in your hands is perfectly fine, but it is important that we do not leave any residual tissue on the cornea. And I feel the safest instrument for this, for most of our cases where the pterygium is not too large or adherent, is a number 15 blade. But sometimes we have cases like these, which are very large. There's adherent pterygia, significant amount of scarring, and just stripping the pterygium tissue from the corneal surface might not work. If you have a patient like this, the questions that we need to ask: has previously a pterygium surgery been done, because this could be a recurrent pterygium? Second, is there any history of any chemical injury or trauma? And underlying these causes must be ruled out before we take up these patients for surgery. So here a crescent knife is beautifully being used by Dr. Namrata Sharma to dissect this tissue from the corneal surface. The crescent is way sharper than a number 15 blade, so we have to be a little bit more careful not to go very deep, and also to avoid a multiplanar dissection. Now, we come to the second, other aspect, important aspect, and then I'll go over the whole surgery, is how to prepare the graft, right? So when we are preparing a conjunctival autograft, our aim here is to avoid getting any Tennant's capsule in the graft. We need to have a thin autograft that sits much better. We can even use a subconjunctival lignocaine or BSS to demarcate the subconjunctival plane here. And it is ideal if we size this graft 10 to 15% larger than the defect, we can always trim it down. Now, typically, like Dr. Praful rightly said, we do not need limbus in primary pterygium. It is a conjunctival degeneration. Yes, there is some amount of postulation of limbal stem cell deficiency that these cases have, but most of these patients do perfectly well just with the conjunctival autograft, and we do not need to take a limbal conjunctival autograft until and unless there is some associated large pterygium with limbal stem cell deficiency or maybe recurrent cases. Most of the cases do perfectly fine without any recurrence just with the conjunctival autograft. So we need to keep also the orientation in mind when we are harvesting the graft. Now let's look at this surgery here. We are anchoring the graft with sutures. So first technique that came in was to use the sutures. So we are dissecting the graft. I've used subconjunctival lignocaine here to demarcate the plane, and here we are using 8-0 Vicryl interrupted sutures, taking the episcleral bites. Now, taking the episcleral bites prevents the ballooning up of the graft and it sits in much better. And the advantage of using 8-0 Vicryl is these are absorbable sutures and you can just leave them in place and you don't really need to remove them, especially if your patient is unable to come for follow-up. Sutures do cause a little bit more inflammation and therefore you might need to give topical steroids for a little longer. So now with this background, let's look at the entire surgery here, and this is what now we do for most of our cases is that we don't put any sutures and we typically use fibrin glue to anchor the graft in place. So this is the same step of removing the head of the pterygium from the corneal surface and clearing off any remnant tissue that we might have. Now, once we have done this, very extremely important step is to now dissect all of this subconjunctival degenerated tissue. We can use a combination of blunt dissection and sharp dissection techniques. We can go in with our scissors closed. That's what blunt dissection means. Go in with your scissors closed and open your scissors as you go in. This would avoid buttonholing of the overlying conjunctiva. And then you can free up all of this degenerated tissue from the underlying episclera. You can even mark it before you start dissecting so that you know how much you need to dissect, and then harvest your graft. So the same principles are of harvesting the graft here are used. Again, see, look at the scissors, how they are being used. We are going in with the blades closed and opening up the blades as we go in. Typically, we can harvest this graft from the superotemporal side. You can ask your assistant to rotate the eye down and take it from the superotemporal side, as most pterygiums are nasal. Now, we are using fibrin glue here, the thrombin and the fibrinogen components separately on two 1 ml syringes, mounted on 26 gauge needle. Then you slide in the graft, making sure the orientation is correct, and then just iron it out. You can take two McPherson's forceps and iron it out. This is a very important, crucial step which I have now started doing in all my cases, is to excise any overhanging tissue on the limbus. What this does is that it greatly enhances the cosmetic outcome. If you have a part of the graft which is overlying the limbus, then again the patient is not going to look cosmetically as good. So what are the advantages now of using fibrin glue over sutures? The first is that it significantly decreases surgical time. This is a Cochrane review which looked at 14 RCTs which was published, and on an average it was found that there are 17 minutes less surgical time when we use glue as compared to suture, which is quite significant. Patient is much more comfortable. There are no suture related complications. There's very low level of evidence to suggest that there might even be lesser chances of recurrence with glue as compared to sutures. Now, surgical time especially becomes important when we are dealing with combined cases, that is pterygium plus cataract surgery, or we are looking at double-headed pterygia. So here fibrin glue comes in very handy. What are the disadvantages of using fibrin glue over sutures? The first and most important is that it is more expensive. That is the major disadvantage. Again, in this Cochrane review, they found out that there was higher incidence of graft dehiscence. There was low level of evidence to suggest that. But we need to understand that graft dehiscence depends on a lot of factors. It is how you do the surgery, how you prepare the graft, what is your surgical experience, and if post-operatively the patient is rubbing his eyes. So here I'd like to share a few tips on how to avoid this problem of graft dehiscence when we are using fibrin glue. First and foremost, meticulous graft preparation, which means that you need to have a thin autograft without Tennant's capsule, without subconjunctival tissue as much as possible. A thinner graft sits in better, stretches better, and gives you a better cosmetic outcome as well. Second is dry the scleral bed before application of fibrin glue. Avoid too much of bleeding on the scleral bed. You can use very limited amount of cautery if needed. That will again prevent ballooning up of the graft and therefore prevent the graft dehiscence. And a very important tip here that we always do for all our cases, use the thrombin and fibrinogen separately instead of using that Diploject injector that comes with the glue, because that causes clumping up of the glue and a lot of glue comes in at once. Here you can control the amount of glue that is coming in. And then using two forceps, just iron out the graft, make sure that it sits in very nicely. And in the end, very important, once we have done all of this, don't be in a rush to pull the speculum out. Trim the excess glue from the surface. If we pull the glue, we are likely to dislodge the graft. So we have to trim, use Vana scissors or whatever scissors you are comfortable with, and trim the glue and make sure that there are no glue remnants attached to the speculum once you are removing the speculum from the eye. We must educate our patients post-operatively to avoid eye rubbing. So these are some of the things that we can follow to prevent this complication. Now, another technique has been described, which is using the autologous blood of the patient. Basically, the idea here is you induce some bleeding and the fibrin in the patient's blood actually adheres the graft. Now, there are some complications associated with this technique. Typically, you can have subconjunctival hemorrhage, graft edema, even graft retraction, or graft loss. So I don't like to use this. I either like to, if the patient can afford, use fibrin glue or put sutures. Post-operative regimen includes steroid eye drops, prednisolone acetate 1%, tapered for at least over 6 weeks. These patients can have inflammation, they can have granuloma formation, so do not taper the steroids very quickly. At least 6 weeks of taper is recommended. Antibiotic eye drops for a week and lubricant eye drops, especially if you've put in sutures to just make the patient a little more comfortable. This is my typical regime. So here to conclude, conjunctival autograft still remains the current standard of care for most of our patients, especially primary pterygium. Thin meticulous preparation of graft is what is needed to achieve success, and anchoring the graft with glue gives us a good cosmetic outcome. It reduces the surgical time and is more comfortable for the patients. Trimming of the excess glue is essential at the end of the surgery. Thank you for your kind attention. And before I end, I would just like to thank all my mentors who have taught me this beautiful technique. Thank you. Yes.
Because I had a ballooning of the graft. It was very big and I was having done it at the corneal side also. So what caused that? Now can I treat once it occurs?
During the surgery or after? So, yeah. Yeah. Yeah, so sometimes they have that granuloma formation. You kind of had a granuloma formation which caused a Dellen effect on the cornea. That's what we are talking about. Yeah, so either there could be a couple of reasons why that would happen. Either there was bleeding from the site under the graft and that could cause ballooning up of the graft, that is more likely, or it could be an inflammatory reaction. So these two possibilities, both of the possibilities we have to consider. Yeah, you can give steroids. You need to step up steroids. Even topical steroids should work. Like you rightly said, oral steroids also sometimes are required, and then in some cases it starts ballooning up and then there is a granuloma formation later on. Again, the treatment remains the same. You have to give steroids. It's probably an inflammatory response if it has occurred on third, fourth day, unlikely to just rebleed on third, fourth day. So you need to step up steroids and give steroids for a long period of time. Especially younger patients, they tend to have more of this inflammatory response. Yes, the tenons being there, again, if the dissection is not done properly and there is some remnant tenons, would actually incite inflammation. Or if the sutures, sometimes the sutures can also incite inflammation. Younger patients have more tendency to have inflammation, but remnant tenons, remnant subconjunctival tissue is a very important factor. Yes.
there to save the disinsertion?
So you're talking about when we use the sutures or using the sutures to remove? Yes.
Keep them for 1 or 2 days and they give sutures, continuous suture without knots, without snot. Just pull it. There is no knot of the eye.
Yeah, we can do that. We can modify the techniques and whatever works well in your hand, sir. Sure.
And I apply contact lens in all the cases because it keeps the grafts pure.
Sure. So I like to apply bandage contact lens only for patients where there's a large pterygium. I've created a large corneal defect that would, make the patient more comfortable and help in healing of the epithelium. But sure, whatever works well in your hand, a bandage contact lens can be applied for sure.
Any other point from anybody? Thanks. Now I request Dr. Sanjay Kumar Mishra to speak on a topic known as mini-select. How does it happen? After the gold standard, the perfect technique has come, and now the perfect technique is amalgamated. We have another technique besides the perfect technique, and that's called mini-select for the technique. And then we'll combine perfect and mini-select as our
Yeah, so what I'm telling that Dr. Ikeda has highlighted about the gold standard technique, and followed by what Dr. Vijay has spoken about the perfect technique, which is another one for management. Now there is another evolving technique that's called mini slit, which will be by Dr. Sanjay Kumar Mishra, and then followed by we'll combine both perfect and mini slit as a permi slit, and then that will be highlighting it.
Good morning to everyone, and warm greetings from Army Hospital Research in Referral, Delhi. I'm Brigadier Mishra. I'm heading the eye department there. So I'm going to speak on this technique of mini slit in primary and recurrent pterygium. Are we going to near zero recurrence? As we all know, histologically, normal conjunctiva, how it looks, it's a stratified non-keratinizing epithelium. And we have started realizing that it's a kind of a proliferative growth disorder. How do we say that? It is based on two factors. That is an etiological factor, when we see a P53 oncogene which is present there, and the induction of pterygium by UV light, and also by behavioral factor, which is because of its aggressive nature and response to anti-cancer treatment. This is how we all know that the gold standard of treatment in pterygium is excision of pterygium with conjunctival autograft. However, Dr. Sati in his publication in 2014 reported a high recurrence rate even with this gold standard, which is up to 3.5 to 10.6%, which is quite high recurrence rate. So, what are the evolving concept in cases of pterygium that we have started realizing that it's a localized stem cell deficiency which gets activated by the UV light. There's a focal limbal cell damage, and prolonged exposure to UV light causes pathological mutagenic changes which results into the formation of pterygium. Also, that it has got similar histopathological features of a pannus which follows a chemical injury, and the presence of Fuchs flex or Fuchs islets, which are epithelial stem-like cells present in front of the head of the pterygium, and which also shows the UV associated damage to the ocular surface disorders. This is how it is shown on the histological staining, which is similar to stem cells, and presence of P63 genes, which is also present in the stem cells. Now, the division, how the new technique, that is mini slit, is mini simple limbal epithelial transplantation. How we decided to do this technique and see about the head-to-head results with the gold standard of conjunctival autograft. This technique was mentioned as a standalone technique in one article from Mexico and showed to be a promising technique. However, there was no comparison with the gold standard. So it required, to prove that it's a good technique compared to the gold standard, we had to have head-to-head randomized controlled trial. So we compared the recurrence rate, complication between the mini-slit and the fibrin glue-assisted conjunctival autograft following excision of pterygium. So we recruited patients with pterygium, and surgical removal of pterygium was to be done in these cases. They were randomized into two groups. Group 1 had the gold standard CAG, and the group 2 had mini slit. They were followed up at 1 month, 3 months, 6 months, and the OPD, and data was analyzed in form of various outcomes, which was recurrence rate and the complication rates. It was a prospective interventional randomized controlled trial, which was done between 2021 and 22 at Army Hospital RNR. Consecutive patient with a nasal pterygium which was extending 2 millimeters into the cornea were included in the study. The excluded criteria included ocular surface disorders, pseudopterygium, hypersensitivity to any blood components, and positive serology for HIV and hepatitis B. They were simply randomized by a computer. Randomization done is by computer generated randomization. The allocation was concealed to the person who was studying this study. 40 patients were included in both the groups. This is what the surgical procedure. See, the pterygium basically, as shown earlier, was excised meticulously. The elements of the head was scraped properly. There was no residual pterygium was there in the residual area, and glue was put on the bare sclera, and amniotic membrane was put on the area of pterygium. A separate place limbal strip was removed, which was cut into 4 small pieces, and they were put in front of the head, in front of the graft, over the glue, and a BCL was put on those pieces. They were followed up on first day, third day, first week, second week, 4 weeks, and at 3rd and 6 months of surgery. The primary outcome was measured in terms of recurrence rate. So recurrence was described as any fibrovascular growth that passed on to the across the cornea, across the limbus to the cornea, and the secondary outcome was in terms of operative time, post-operative symptoms, and other complications. The post-operative symptoms were graded from 0 to 4, where 0 was no symptoms and 4 was symptoms completely interfering with usual activities. The symptoms of foreign body sensation, lacrimation, pain, and irritation. So we recruited little extra because knowing that the patient will be lost to follow-up. We had 92 patients, 10 were lost to follow-up. We had 42 in control arm and 40 in the study arm. The basic characteristics in both the groups were almost similar in terms of age, gender, laterality, occupation, and preoperative best corrected visual acuity. The recurrence rate was slightly higher in the CAG group as compared to the mini-slit group. However, it was statistically not significant. The recurrence rate was 3 in the CAG group, which was seen at 3rd month, and 1 at 6 month. And in mini-slit group, the recurrence was later, that is almost at 6 months in one case. And all these cases which had recurrence required resurgery. As far as the operative time is concerned, the CAG group was less operative time as compared to the mini-slit group, which was statistically significant. The ocular discomfort and other symptoms like foreign body sensation, lacrimation, pain, and irritation were also charted and did not show much difference in both the groups. The other complications were like graft retraction, graft displacement, subconjunctival hemorrhage, Denon formation, displacement of limbal pieces, and sub-AMG hemorrhage, which was almost seen in both the groups, so not that much of statistically significant. If you see, the graft retraction displacement was not seen in the mini-slit group. However, the mini-slit group had displacement of limbal tissues and there was sub-AMG hemorrhage. This is the CAG group which is seen over from day 1 to 6 months. You can see good surgical results, as well as also in the mini SLED group from day 1 to 6 months. This is the top one is the CAG group, and the down one is the mini SLED group, which is almost similar. You can't make out the difference between the two groups. The current study highlights a positive trend of less recurrence in the study group. In addition, the post-operative symptoms and overall rate of other complications seem to be less in the mini SLED group. Why do we see a less recurrence in the mini SLED group is because of repopulation of the abnormal limbal stem cells by the normal limbal stem cells, and also the anti-inflammatory properties of the amniotic membrane. Is the more post-operative time justifiable in the mini SLED group? So if you see in the terms of less recurrence, future expense on repeat surgeries and associated complication is minimized. Is mini SLED advantageous? Is likely to restore the normal anatomy of limbus. It preserves the superior conjunctiva and is highly suitable for patients who have limited conjunctiva, especially if you have a glaucoma patient. So yes, it is justified. So what was the uniqueness of this study? This is the first study of its kind which was studied head to head between the gold standard and this group. Secondly, the study has given a hope for a recurrence-free pterygium surgery for the future. And considering the impact of mini SLED in terms of less recurrence, this study further validates the evolving pathogenesis of pterygium, that is UV light-induced limbal stem cell deficiency. Based on the findings, the authors recommend mini SLED group technique, suitable alternative to the in terms of less recurrence and less post-operative discomfort and other complications to the standard CAG. However, the data size was less, so we require a larger study group and more randomized controlled clinical trials to prove that yes, it has got a definite advantage over the gold standard. Thank you.
When we take the graph, it is recommended that you go, you're taking go into the limbus, you include part of the limbus.
Yes, you
put that graph there on the bare area, that amounts to almost same thing.
So the strip of graph which is taken is very less. You're just taking a strip. You're not taking the entire conjunctiva. You're just taking a strip of the limbal tissue and cutting into smaller pieces.
We know slits, but they done with so many other procedures also. So what I'm saying, when you're taking a graft with it, you're including a limbus into your graft and putting it amounts to the same. That you are transferring your stem cells from the
Exactly.
to the
Absolutely, sir. Absolutely. Yeah, please.
So here we are transferring a very small limbal piece, unlike in the conjunctival autograft that you're talking about, conjunctival limbal autograft. So in bargain, what is happening? The normal site of taking conjunctival limbal autograft is superiotemporal. That's you must be taking normally. So at least you are saving it for the future surgeries. So this is how the minimal involvement of tissue in achieving the same functionality is the idea.
Yeah,
That's
so
the current concept.
That is the concept, that you're taking just a small tissue only, not the entire conjunctiva. So you're saving the entire conjunctiva there and just putting a strip, which is giving to the same effect of putting the entire conjunctiva. Yes.
Any other point from anyone?
It's very heartening to see that on the last day, so many people have attended this IC, and it goes on to show that the basic things in life is what is more important than the advanced things. You have one, huh?
Thank you.
Yeah, please. Combine cataract and pterygium. Why do you want to combine these two surgeries? So it is always when you have a pterygium and a cataract, you prefer you do, because of astigmatism, you should do a pterygium surgery first, neutralize the astigmatism, and then go for a correct IOL power calculation, because ultimately you will then end up, suppose this patient, you have a large astigmatism, you go for a toric lens, and later on this patient undergoes for a pterygium surgery, this astigmatism is neutralized, So the effect of toricity is gone, and the patient is going to be uncomfortable later on. So you do in two parts. You don't do like a phaco trap in one sitting. You do a pterygium surgery first, neutralize the astigmatism, and then go for the cataract surgery.
Huh.
You should wait for the complete recovery of the pterygium when you know that it's all healed up.
So,
Maybe 2 months.
Sir, I'll have a different different point of view to answer that question. So what I do is I do combine surgery in some cases. I do because some patients would not want to have two surgeries. So what I do is you do a preoperative assessment, do a topography, and do if you have optical biometry. Look at the topography and see how much of an effect is really the pterygium tissue having over the cornea. There are studies conducted to actually measure the length of the pterygium, and they compute the surface area that is on the cornea, and look at the astigmatism that it is inducing. Typically it will induce flattening in that meridian. So if the astigmatism is typically less than 1, less than 0.75, the pterygium is not too large, you look at the topography, it's not really affected that much, these are the cases that you can combine in the same sitting. So once you're combining these cases, I think your question was the order of how you operate, right? So because these typically the patients that you're going to combine are going to have a small pterygium. You're not going to combine something that's coming over the pupil with the cataract surgery. If the astigmatism is more than 1, then definitely do a pterygium surgery, wait for 2-3 months, and how do you know when to operate? Do a topography. Make sure the topography is stable. Make sure the biometry is stable. Repeat topography and biometry when in doubt. And if you have stable readings, then that means now the patient you can take up for cataract surgery. Now, if you're combining a small pterygium along with the cataract surgery, that small pterygium is not really going to hamper your view as much. If your view is good, do the cataract surgery first once you're done with it, because you finish the intraocular part, and then you do not contaminate any instruments and move to the extraocular part. Only very, very rarely, if you have a large pterygium and you're unable to emulsify, because if you're doing a temporal incision and the pterygium was in the nasal side and you're unable to chop effectively, then you might just excise the head of the pterygium and leave it at that, change those instruments, then do your intraocular phaco and do the rest of the steps once you're finished with the cataract surgery.
I think
That amounts to
we
the
as
same thing. So what-
Indians, I think we as Indians, we always look for the objectiveness of anything. So you must be thinking, see, if you have a astigmatism of 0.75 or less, I think you can go ahead with the combined surgery. If you have more than that, then definitely go for the pterygium first, followed by
So it's the
cataract
same
surgery.
thing, where it's causing a large astigmatism. Let the astigmatism be taken care of first, because you're not going to have a good post-operative results in a cataract surgery. Yeah, ultimately what you're gaining is you want a good visual outcome.
No vision is common figures only. Removing the pterygium the patient will not be satisfied unless otherwise there is no visual outcome.
So that's what.
Better do the cataract surgery first.
No,
Make the patient objectively satisfied, then go on for the pterygium removal.
No, it's a well
No.
described in literature now. If you look at the objectiveness is very clear cut, sir, 0.75. If it's atrophic,
not
less than
causing any-
0.7,
why remove that pterygium? That's again this thing. Basically, then he only comes for a cosmetic reason. You say cosmetic reason.
Generally just approaching the cornea or just covering the limbal region. Leave it. Do the cataract surgery.
So that's fine. So this pterygium is only for cosmetic reason. Then
Sir,
it's not hampering the vision.
if the pterygium is crossing the pupil, we do the cataract surgery, we won't be able to do IOL power calculation, no sir. That's the main problem.
That is the essence situation.
Yeah.
Once it's crossing the pupil,
then it is.
what all of the exercise we are doing, that purpose is will there.
You can introduce me before going. Introduce my topic before going.
The remote area, yes, you can find.
They are blaming everything to the devil's case. I have got 3 cases. They are telling.
Yes, sir, you were asking something, sir.
Some cow was traumatized the cornea. Usually in our place, pterygium is very common and it's in rural background. Patient doesn't want any fancy cataracts or fancy IOL and anything. They just want a basic vision, monofocal basic cam surgeries or monofocal basic Indian IOL. So in that case, these all biometry and topography, we
No, we're talking about only standard conditions. That is always up to the treating surgeon how he responds to the situation, where what the basic thing is the requirement of the patient, what he wants. You have to see that.
No, you may not be having optical biometry or topography, but keratometry invariably you will have, so you can check how much astigmatism is
But
there.
of course, if you have a mature cataract and the patient only wants visual rehabilitation, you have a small pterygium, of course, you can leave it in place. Absolutely.
Yes,
Why not? If the
absolutely.
patient doesn't want it, we don't have to touch it. Yeah. Yeah. So now can we have our next speaker, please? Professor Alok Sati. He has published extensively on pterygium, and today he is going to talk about how to what happens when we combine the perfect technique with the mini sled, and are we achieving zero recurrence? Dr. Alok Sati, please. Thank you, sir.
Yeah, very good afternoon, everyone. The topic is pterygium extended removal followed by minor ipsilateral simple limbal epithelial transplantation. So we have done this newer technique in a couple of patients over past few years because of less recurrent patients that we receive in our OPD. So how the thought evolved, like, there was a 61 years old female who came with recurrent pterygium and symblyferon, and she was operated twice elsewhere, and she was quite rigid that she didn't want further surgery. It's very troublesome for her. In addition to that, she was also suffering from primary open angle glaucoma, both eyes. Now the point is that we have to treat recurrent pterygium and we have to think about glaucoma also, because she may need glaucoma surgery in future. So is there any answer for that? Yes, we reviewed the literature and we found perfect technique as highlighted before by the previous speakers, where the recurrence is quite less because she wanted no recurrence further. So we reviewed the literature, we got only this technique where there is hardly any literature, hardly any recurrence. So if you look at this literature, the recurrence is to the tune of 1 recurrence in 1000 surgeries. And in recurrent pterygium, it's again from Dr. Hurst only from Australia, where there is no recurrence in 111 consecutive patients. So now question arises, is perfect technique is advisable in our patients? That's what the question, because the patient is suffering from glaucoma. So of course not. So can we modify this perfect technique? So we did what we did. Instead of taking a large conjunctival graft, which may be required, in case of future trabeculectomy, we did the pterygium extended removal. Like we removed the entire tenon and the whole fibrous tissue up to the medial canthus, but we covered it with the amniotic membrane, and we placed 4 pieces of limbal pieces at the at the neck of the pterygium or at the limbus, and that's how we innovated this newer technique. So this is the surgical video for that. We are dissecting it from the head, and now this is the symblyferon. We have to dissect the symblyferon, and this is the subconjunctival tissue that we are now removing. So you can appreciate that the pterygium can be so extensive like this. Now what we are doing, we are now removing the conjunctiva, tenon, and the fibrous tissue up to the medial canthus. We are trying to expose the medial rectus very clearly from all sides. And now we are doing the fornis forming sutures, fornicial forming sutures, what we call, because we have to form the fornix also in this patient, otherwise there will be again symblyferon formation. Now you can see that the medial rectus is well exposed. We have removed the entire fibrous tissue. Now we are placing the amniotic membrane on top of it, making it adhere with the fibrin glue. And now this is the limbal piece that we are dissecting, about 1 clock hour position. and we'll split it into 4 pieces. We'll place them over the at the limbus here, and will make them adhere to it with the help of fibrin glue, followed by placement of the bandage contact lens. So here what we did, we combined the per of perfect and mini slit, and that's how we innovated a technique known as permi slit. And this is the follow-up on day 1. You can appreciate the 4 pieces here. This is day 7, 1 month and 6 month post-op. But there is no recurrence at 6 months, no Simlifron, good cosmesis, no ocular restrictions, and the most important is that we have preserved the conjunctiva for future glaucoma surgery. So we started our journey from here with such an extensive pterygium with Simlifron, and here you can appreciate that there is no ocular restriction. We have done this procedure in couple of more patients with no recurrence. So it is just the patient requirement that has led to this newer procedure as permi slit. What is most important about this procedure, that it enables us to complete an extensive removal of the pathology. We preserve the conjunctiva, we have got the anti-inflammatory benefit of amniotic membrane, and we have achieved replacement of pathological stem cells with normal stem cells. No surgery is without complications, so here also we encountered one granuloma which we subsequently excised. What is most satisfying is that there is no recurrence, no Simlifron, and there's a good cosmesis with no ocular restriction, and we have preserved conjunctiva for future glaucoma surgery. I think the take-home message is very clear-cut. It's a promising technique. It has an ability to change the practice pattern, and a large cohort is required to conclude the results. Thank you.
You cover the cells, those pieces of the you've taken, you planted over the amniotic membrane with the contact lens or anything,
Yeah, we have to cover it.
because otherwise they will.
They invariably don't get dislodged, especially in adults. We have seen them in youngsters basically who are more active. But if you made them adhere to the fibrin glue and place because they are very precious commodities, so better to cover them with the uh, bandage contact lens.
These good results, what you've said, why should we have that big conjunctival autograph and waste that area for the future glaucoma surgery?
That you have to ask Dr. Hurst. He innovated it.
Very easily we can adopt this.
Yeah.
So
that's
that
Way better.
yeah. So this the idea of presentation of this IC was to make you aware that this new technique of innovation and using just a small strip of conjunctiva can give a very good results with hardly any recurrence. So one should switch over to this surgery and save the conjunctiva for future surgeries.
When should we remove the contact?
So in our center we remove at 1 week, but there is no specific. There's nothing.
Sir, how do you deal with that excessive bleeding? Because generally in the recurrent pterygia, because of the fibrosis, I think we all face that. So do you have some tips on that? And another question is the multi-headed pterygia in recurrence. We tend to dissect and then either it's incomplete on one side, so we don't want multiple lamella being separate. I mean,
Yeah.
at multiple levels.
To the
These two are generally issues with recurrent with this type, and we get a lot of this type of recurrence.
No, if you have a multi-head pterygium, like if I show you here, this is multi-headed, double-headed pterygium. So yeah, double-headed pterygium, this surgery works quite well because you just have to place amniotic membrane. You have to dissect till medial canthus and lateral canthus, place just the amniotic membrane, and take a small piece of limbus, either from the same eye or from the other eye, and then.
Question was on the cornea. We
Hmm.
have to avoid this multiple levels of dissection. So very often the heads are at different levels. They're not placed at the same lateral level.
Yeah, that's experience, ma'am. With that, you can do it. It's easily doable. Dissection is not a issue especially for the corneal surgeons. So it is manageable. And about the bleeding part, yes, you can use cautery. That what we use. We use gauge pieces, small gauge pieces soaked in adrenaline. That's another thing which we use at our center. And the third one is you can use thrombophobe also, because there are, they are also available. Thrombophobe, they are white powders, which are basically that also you can use. Any of the three.
So idea is to have a good hemostasis before we proceed further. Yes.
Even during the dissection of the demons, it bleeds much more. Like,
Yeah, definitely it bleeds much more, so you have to have lot of patience while surgery. Very important. Don't be in hurry. It takes time. It will take time. It will take at least 1.5 hours to do this procedure, and you have to keep, you know press those parts with the help of gauge piece soaked in the adrenaline, and of course the cautery.
Which instrument do you use to take the limbal part, limbal cells?
We use Westcott scissors at our center. Westcott and LIMS forceps, and also the Macpherson. These three instruments which we use.
How about you, if you like to use the crescent knife?
Yeah, and crescent knife also, because we have to dissect. See, limbal piece which we take, it has to have some amount of cornea also into it. Yeah, it has to have some amount of cornea also into it. Otherwise, they will not grow, because cornea provides niche for them to grow.
So it is crescent knife has to be used.
Yeah, crescent has to be used.
Would sliding the conjunctiva have the same effect as an independent conjunctival transfer?
Sliding means from where, sir?
When you open the pterygium, you slide the conjunctiva from both sides together.
Medical, so medical.
No, that we have no experience. We have no experience. It's just like using, that rotatory graft in
Yeah.
the cornea. So that's out of vogue now. That's no more.
There's not
done.
no more being done.
Yeah.
I know it's not being done.
Yeah.
It's not being done because probably the results were not very satisfactory. So the recurrence is very high in these cases.
Conjunctiva is the same, whether you want to not good.
Say removing that advancing head, that's like our now still 2-3 cases going very smoothly. What we are thinking of throwing away in the dustbin, you just remove the head of the advancing tertium, take that residual conjunctiva, upper conjunctiva, let me see, bulbar conjunctiva. The same can be reversed and it's right there. Or one last 2-3 is still there without ballooning out, without going away, it's still there.
The whole tissue is diseased.
No, that part you remove. The remaining that part, the all part how we can degenerative part is approaching and going on. The maximum you
So there is a lot of fibrosis. Very difficult to. Yeah.
Technically.
Very difficult to remove actually.
In the literature, any reports of major surgery not during the direct surgery, but normal surgery surgery. Any frequency of medial rectus getting damaged during that?
Oh, acha, acha. No, we haven't got any such complication. Literature, yes, the literature has stated even the whole. There is a ocular restrictions because of fibrosis. People have, touched the medial rectus, and that has led to the but we haven't. It's not possible. It's doable, and you have to have squint specialists with you. It's very good if you have, who knows how to handle the muscle.
You have to be really meticulous. You have to be really well adapted to damage so many structures.
Any surgery can cause some sort of a complications.
Then you'll be a traumatic surgeon.
So I think
Thank you so much for beautiful presentation. I think it was very nice to see the evolution of pterygium, the modification of pterygium, and the use of innovative techniques in pterygium surgery. And I'm sure this has gone well with the audience. They have a lot of queries, and this is a basic surgery which is the most underperformed, most under-talked surgeries. Yet good technique can give a very gratifying results. Thank you.
Thank you. Thank you all.